Robyn Whittaker. Robyn, you're the lead innovator at Waitemata DHB, sorry. And you came today to talk about the Leapfrog program. Can you tell me a bit more about your Leapfrog program?
Sure. So the Leapfrog program is a program of strategic projects that the program is sponsored by the CEO, and all the projects in it are things that he thinks and we think will take us on a big leap from where we are now to where we want to be. So we have a future vision of a health service that is more digital and more mobile, and all of the projects are small incremental steps that are helping us build that culture of moving towards a more innovative and a more digital and mobile type health service.
Sounds excellent. And it sounds like the CEO is on board, which is important.
It's been incredibly important actually that both the Chair and the CEO are really supportive of this program, and they're really pushing it, and they talk about it all the time. So Dale reports it up to the board all the time, the progress against all the projects, and he talks about it a lot with all the staff too. So it's given that really high priority and high visibility from the top down.
Lovely, cool. And so who does it involve? This sounds like quite a large project, so who have you got on board?
So we have a Leapfrog team of people who are involved, and each of them lead one of the project, but they also work collaboratively as a team. So we have some fantastic people. A lot of the clinical leads, like Lara Hopley, that you will have heard from today as well. So she's an anaesthetist and she leads one of the e-orders projects. David Ryan is a pharmacist and he leads the e-prescribing. So it's a really important mixture of those clinical leads and the IT leads, like Andrew Cave within our organisation too. And then also on our team we have the support of some really important executive and senior management people, like our CIO and the Director of Institute and Associate Director of Nursing. So they give it a lot of oomph and a lot of support to make these things actually happen.
Okay, so it sounds like most of the people that are involved have been involved in the hospital already, is it?
Yeah, so everyone's come from within the organisation basically, so they're all bringing their own expertise and background, but they're also bringing all of their networks, and so they can go back and talk to their colleagues and spread the word and be the champions for their projects as well in that way.
Okay, and I like the name Leapfrog. It kind of makes sense. You're trying to jump across to a vision that you want to achieve, which is mobilising. Does it mean that the hospital's not going to have paperless documentation, or?
Well, whether we would ever get completely paperless, that's quite taking it quite far, I guess. But yes, certainly that is the end vision. That is a major clinical change for the way people work on the wards, to be much less paper focused and have processes that are paper driven, to be much more about being able to access information and enter information wherever they are. So at the point of care, wherever that might be, or remotely, that they can still see all the information that they need to, and that they can update and add information as they need to as well.
And what are they using? Like, is it like a laptop, or is it a phone, or? So
all different devices. That's been one learning, is that we have to map the type of devices to the different parts of the system. So what's going to work best for everybody. We have our community allied health. A lot of the community services had tried using laptops before and it didn't really work for them, but they're loving using the full-size iPad that works perfectly for them. A lot of the wards like the computers on wheels, the cows, because it also gives them a platform to put things on and to lean on, put notes on. And then in other areas of the hospital they have no space for cows, then they wouldn't have enough space for the number of devices that they would need, and so they're using their iPad minis.
Right.
And our nurses, for example, with e-prescribing and e-vitals, are all using the iPad mini, and it happens to fit into the pocket of a nursing uniform, so it's easy for them to carry around. So we've had to mix and match a little bit to meet people's needs.
Great. And how are you finding with the clinicians taking on, I guess, like a new way of documenting or technology, essentially? How are you finding that?
Yeah, well, it is a challenge to get everybody on board, and we often have the really keen people, and then the big group in the middle, and then the people who are the skeptics at the far end. So it's really important that we have our clinical champions who can go in and talk to people, because they understand the job, so they understand what the issues might be, and they can interact with them, and they can also adapt the program to better meet those needs, so that clinicians feel like they're being listened to. If they say, look, this just isn't going to work for me, that somebody who understands their job will listen and say, okay, but how about if you did it like this, or how about if we gave you something slightly different instead. So that's really important in getting them on board. But also finding out about their training needs. So we've also discovered that the different clinical roles will interact and engage with training in quite different ways. So we can set up multiple different ways of doing training so that it will suit the different needs. So we've we've found that doctors don't like to attend training, and they often won't attend training before a system is implemented.
Yeah.
But if we put in place what we call the red shirts, so they're knowledgeable people who will be on the floor in the first few weeks of a change, and who will be available to answer any questions, and they know what they're talking about because they're often both clinical and have a really good understanding of the IT system, so they can understand the need and they can understand what the solution might be, and they can do the training as we go, basically, sort of at the elbow, we call it.
So you found the doctors didn't want to know about it pre to the program coming on the floor?
Well, a lot of them, a lot of them. It's obviously, it's great to involve some of them in the design and the development. So the really keen ones, we love to get involved early on, and so that they can give us that really early feedback. They can be the pre-testers, the early adopters, and they can tell us what does and doesn't work, and we can really make most of that advice that they give us. But then there's another big group that really don't really want to know or find it difficult to think about how it's going to affect their practice until it's actually there and they get to play with it. And then they say, oh, now I understand.
And that's really good that you've got people there that can give them help or advice, and that way in return they also get instant feedback on what's working and what's not working. And do you adjust it to
absolutely
what they've got?
Absolutely, we can adjust it, and that's been that was one of the things that Lara mentioned too in her talk, was that then the training's not just about one specific system or one specific change. Those people are so knowledgeable that they can say, well actually, I'm teaching you about this new system, but I noticed that the way you've got your desktop, it's not very handy for you. You have to be using lots of clicks and going lots of different places. How about if you just set it up like this, and then this is how you could use this system better and that system better, and then you've got a much better layout for your desktop, and and that's a big part of it, I think, because then they're making the clinician's job easier, and that's when they'll engage. If they really get the idea, actually, if I do all of this, it makes my whole life a whole lot easier, and therefore they're much more likely to engage with us the next time we come around.
That's absolutely true, and I guess it's a natural response for us to revert back to something if it's not going to work for us straight away. But if you do find something is efficient and is going to help us, we will adapt to it, like the cell phone or...
Exactly. It's got to make clinicians' lives easier.
So what have you learnt from this program as a whole, apart from the clinician's challenge?
Well, there's been an awful lot of learnings, right from needing that really vital support from the top for this whole vision, to having the right people on the ground doing the work, but also our other main partners, our Health Alliance, is our IT support, so having them involved the whole way through, right from the very beginning, which we didn't used to do. So now we know that we need to have a little bit of investment up front to get all the right people on board to help us plan it from the very beginning, and then we're much more likely to go smoother throughout.
That'd be quite tricky, wouldn't it, to have, you need the money up front to try and make the adjustments early, to make the program work essentially.
Exactly, and I think that's been part of the Leapfrog program approach, is that recognising that these projects are in a bigger program of work. It's not just individual projects that we go to ask for money for one at a time. These are all part of a bigger vision, and people sign up to these particular streams of work happening within that, and that allows us to invest in them up front, really, put aside that sort of seed funding so that we work everything up properly and we make really good decisions about what projects will progress.
And are you able to just list off some of the Leapfrog programs? Like you've got e-prescribing and some sort of radiology one as well, don't you?
So we've got e-prescribing, which is just coming to an end. Electronic vital signs system is Canterbury and us are the first DHBs to put that in place. We have voice to text, speech recognition technology, the electronic ordering systems, both in labs and radiology. And we have the mobility strategy, of course, which has been underpinning almost everything that we've been doing within the Leapfrog program. And we have some other programs that are less IT related around improving outpatient clinics and more future-focused facilities design.
And so where to from here? You talked about phase 2 in your talk. So we're just getting to the point where some of these projects are finishing, and we're starting to think about what will be the next phase of Leapfrog, and we're just starting to have these discussions with our board and our CEO and external experts and lots of other people, really. But one thing that we've sort of grabbed onto, I guess, is we just had a recent visit by John Halenka, and he gave us this acronym, which is SMAC, which is Social, Mobile, Analytics and Cloud. And it fits really well with the sort of priorities that our DHB has. So we've been thinking a lot about patient engagement and where we're going to go with that in the future, and rolling out our current patient entertainment system that we have on iPads on one of our wards.
The analytics is going to be really important in the next phase.
Because you're going to be collecting a lot of data.
We're collecting so much more data
Yeah.
electronically, and we really need to be able to make the most of that. So we want to be able to integrate all of those data sets, we want to be able to extract data, and we want to be able to do research on that so that we can really provide the next level of clinical decision support tools for our clinicians. And mobility is going to continue to be really important as we're able to develop apps now within our system for our clinicians. And we're wondering if cloud is the next big thing for us, the next strategy after mobility.
Yeah, it's cool. And of course today you've got a lot of presentations going on in the HINS conference talking about the projects within the program.
Yes,
right?
So a lot of the clinical leads and myself, we're presenting some of those individual projects.
It'd be great to hear them. Well, thanks very much for coming along and having a chat with us today.
Great, thank you.
See ya.
Bye.